and she's, did that just shut down? Okay, well, I don't know. My phone just said it shut down. Maybe it didn't. I don't know. So she's clutching her chest, and she's breathing, slowly, and I said, are you okay? I still had my stethoscope on, didn't touch anything. And she says, she goes, "Oh, this is what it felt like when I had pleurisy." Okay, stop right there. Didn't even go in the room. Immediately went to tell the nurse, and sure enough, shipped her off to have a chest X-ray, and they ended up sending her to the hospital. So yeah, that's pleurisy. So when you have something super um, dangerous or something concerning you, you need to do something about it immediately. And as soon as I saw her, I knew exactly what that meant, and that was pretty obvious, right? So we're not going to get into blood pressure obviously this time, and this is what I'll tell you about your saturation. And I got some pet peeves about this one also. For those of you that know me well, stop trying to get an O2 sat on those big fat man hand fingers that double as crescent wrenches when you can see their actual fingerprint through the black staining of their mechanic hands. Stop thinking that O2 sat that fits on there like this, like it doesn't even clip on. It's literally like this because they basically have 10 thumbs, right? Stop thinking you're going to get a realistic reading on that. That drives me insane. Use an earlobe, use the nose, get the forehead one, or get maybe their pinky. If I've in the past, it literally before surgery, I have in the past had them take off their shoe and their sock before I even get them undressed, and I've tried that toe. Remember the third toe. For whatever reason, the third toe is the go-to. That's where you're going to get a much more realistic reason. Yes, it's farther away. I get it. It's distal, and yet you'll get a better reading because instead of trying to use those fingers that have been worked over for 50, sometimes 60, 70, 80 years, whether they're diabetics, smokers covered in nicotine, whether they're farmers where they don't even use gloves, they just hold a bale of hay in each arm while, walking out to the field. Those fingers are so indurated, they're so thick, they're not going to have that capillary reading that they would in that soft little toe that's been protected in their steel-toed boot for so many years. So be realistic in getting that reading. When you get a reading of 91 or 92% and the patient is pink, awake, alert, and talking to you, and that's probably not a real reading. And I have cured quite a bit of hypoxia in my time. So did I fix them or did I get a realistic reading? And it happens all the time. We go to the recovery room and the CRNA hooks up their O2 while the rest of us are, getting them all hooked up and getting some vitals, and they, crank them all the way up because in the OR, they were reading low. So a lot of times in my experience, especially this one, I always tell the story of this little smoker lady who preoperatively was like 89%, and the nurse writes on the board, her O2 is 89%. So the anesthesiologist doesn't say a word, and the patient goes on to surgery. Now, if this patient was hypoxic, truly hypoxic before surgery, she's pink, awake, alert, talking to you, no shortness of breath, no difficulty breathing, nothing like that. Pink, alert, awake, talking to you, no issues, but 89%. So the nurse writes it on the board, and the anesthesiologist is like, sure. So patient goes to have surgery. Ironically, I happen to be the one to recover her. So as soon as she gets there, I know she's been a smoker for years, and I immediately take that O2 sat off and I put it on her toe. I turn the oxygen back down to 2 or 3, where it should be with an awake, alert, oriented, healthy patient after surgery. And she immediately goes from the 82% she was reading when she came to recovery to 97% in a matter of 30 seconds. Did I cure her hypoxia or did I get a realistic reading? I took it off her nicotine-covered fingers. For all I know, she could have also been diabetic. I don't remember. This was years ago, way before COVID, that sort of jazz. She could have been a knitter. She could have been a sewer. She could be, your average horse girl who's covered in calluses and, indurated fingertips from constantly, cutting yourself and hurting yourself and doing all kinds of outdoor things. That's what happens. So those fingers are not realistic reading. If you can't get one from the earlobe or from the nose or the forehead one, then go to a finger or a toe that is going to give you a realistic reading. And when they're pink and alert and talking to you, it's probably not a realistic reading. Even those COPD patients, a lot of times I can go to the toe and get a realistic reading, have them purse lip breathe. If you go from 89 to 95% from purse lip breathing or changing where it is, well, then you cured them. There's no note needed. You don't have to assess, notify, and treat them if common sense interventions fixed them. But recognize the problem. When you see somebody in respiratory distress, you will see it here. You don't have to read it on a monitor. You will see it here. They are wide-eyed. They can't catch their breath. They are scared. That is a true respiratory distress issue, and their SAT may reflect it. When you get an abnormal reading on your O2 saturation, recognize that may just be a poor reading. And I've even had CRNAs, some that have, since retired, that, they kind of said something to me like, oh, Gina's using the third toe again, oh, go to the third toe. And they'll kind of make a joke about it. I even did so with an anesthesiologist, went out on a limb. I was a little scared, but the SAT, for whatever reason, I think this was kind of a man hand, giant, diesel mechanic finger kind of guy. And his SAT kept reading and beeping from the monitor, low SAT at like 89, then I could get him to go to 90 if he, took a deep breath. Well, we're getting ready to do a block. And this particular anesthesiologist, whom we all love and fear, he may or may not have a little short wick when it comes to a beeping monitor when we're both busy and our hands are full and we can't stop it from beeping. So I went straight to the toe. And he did not like that. So he put it back on the finger and it started to beep. And I said, I promise you, on the toe, it quit beeping. And I put it back on the toe and it went straight up to 98%. It went from beeping at 89, which I knew he was not 89. This was like a 30-something-year-old healthy man. He wasn't even a smoker. He had no pulmonary history. For whatever reason, it's just not reading on his big, thick, indurated fingers. So I put it back on the toe, cured his hypoxia. The doctor gave me a little, half smile / smirk nod. God forbid he say something like, okay, you may have been right. That's never going to happen. And I've accepted that. And it shot up to 98%. We did the block, no problem. And, he didn't say a word and finished and we went on, but I knew what he was thinking. Get a realistic reading, okay? I even had a patient say that during his sleep apnea study, they put him on a CPAP and that sort of thing. So he was one of the gentlemen that I actually had take off his sock and shoe. And this was way before COVID because his wife was in the room and I remember. And I took it off and I went to the third toe and it was 98%. And like the look on his face when he looked over his wife and they were both like, are you kidding me? I said, well, did they have that O2 sat on your finger during the sleep study? Which I knew they did. And he was like, well, yeah. And I said, well, that may not have been a big of an issue as they made it if they got a more realistic reading. It doesn't mean he doesn't have sleep apnea. It doesn't mean he doesn't stop breathing during his sleep. But as far as his O2 saturation, that may not have been a realistic reading on this big giant farmer man hands. And the ones I'm talking about, where you literally can't, like I even have the ones where the little squishy ones, the gray squishy ones with the blue cord, I literally can't even get their finger in it. Right. So is it going to read correctly? Is that red dot really going to get through, that nail and that thick indurated tissue? So get realistic readings. And then when you have a realistic reading, you're like, okay, this is real. I've checked it 5 different times. And I've been known I'll change monitors, I'll change cuffs, I'll change positions, I'll leave the room because I tend to have a hypertensive effect on some patients. So I will do all of those things. And if I can't get it better, then it's real and we need to do something about it, right? Okay, so that is your vital sign little mini video there. And if you've got additional questions or anything like that, we'll get to it. And I'll be glad to answer questions. I'm not going to entertain, well, I had a patient that did this and you're wrong. And okay, well then I'm wrong, click out, that's fine. I'm here for my students. I'm here for the students that I'm not going to be able to reach in the future. And I'm here to reiterate some stuff for students in the past. And like I said, this is not like my opinion. This is 26 years of me paying close attention. This is me doing my little experiments. This is me having 20 patients in one day, three days in a row, each week for the last almost 15 years with my students and doing those experiments also, seeing if we can fix it, seeing what we can do to change it. So like if you've got an O2 sat that is 92% or, because we can't chart below 95 at some, skilled facilities, and you notice their O2 is on the floor, well, put it back on. Get them doing their pursed lip breathing in through their nose, slowly out through the mouth, hold it a minute for just a second in their lungs so they can exchange, give that oxygen time to exchange. and then test it again. And if you cured them, well, then the note may be that they need to keep their oxygen on, and all staff needs to be, reiterate that in the care plan, that all staff need to make sure that this patient is complying with their O2, right? That doesn't necessarily mean that their saturation is low. It means that they need to be compliant with their oxygen to make sure their saturation stays realistic and where we want it, right? Okay, so that is about it for vital signs. I may have missed some stuff, but Lord knows I'm gonna circle back. So I tend to reiterate things because I know you need to hear them, 30 or 40 times before you get it. And I get that. So we'll do that again later. And in the future, when we talk about other medications or disease processes, we're going to touch on those vital signs also. If you've got questions or stories that I can add in next time, I'll be glad to do that. And as always, I'm going to end this with a little pet peeve. Pretty simple if you know me. It's my basic pet peeve, so I'm just going to run with it. It is wrong. It is wrong to make people around you ever have to hear what's going on inside of your mouth. For the love of God, chew with your mouth closed. It's that simple. Please. And I know I'm tagged regularly on Facebook with that little needle point that says, if I've heard you chewing, I have fantasized about your death. And that's true. Some of my friends can even attest that I have gone in and fish hook them. Literally, I will fish hook you and go in and get that gum if I hear it. And you know who you are. Some of you are too beautiful to make that much noise with your face and just a small piece of gum. It's unnecessary. And I certainly don't ever want to see it, for the love of God. Don't let it hang out the corner of your mouth. That's wrong on so many levels. It's wrong to the public. It's wrong to any around you. I recognize people on average don't realize the horrific noises and sounds you make, but you know how I feel about gum. Especially popping gum, those of you that do it around me on purpose. I've not only fantasized about your death, I may have even taken some steps toward it. So do yourself a favor and just quit with the gum popping. It's horrific. Nobody needs to hear it. No one needs to see it. It's disgusting. And we all know that. Don't make me know what's going on inside your mouth. Okay, it's bad enough that you suck your snot up in the back of your throat and swallow it in church, and I have to listen to it. And I can't really give you the look, the look to help you learn. That look. You try to give it to people while you're driving. I gave one yesterday who came to almost a complete stop before trying to get on the highway. Could have killed us all. God bless them. I don't know how they're allowed to drive. Oh, and if you want to know about any makeup that I'm wearing today, I listed it all in the comments. I'm just kidding. I don't even know how to do that. Or the description box. I don't even necessarily know what that means. But I don't even know what I used on my face. Half of this crap's probably expired. I have a serious makeup collection, and I just use whatever I can find. And if you're wanting to know how I managed to match this so well to my blouse, I can't teach that. That's just a gift. Sorry. You're either born with it or you're not. So it just is what it is. Okay, so I hope that was somewhat helpful. I know it wasn't too detailed. When we get into blood pressure next week, y'all hold on to your butts, okay? Grab some paper, pull over, because we're going to get into blood pressure pretty hot and heavy next week. So I look forward to that. And I hope I may have cleared some little things up. Again, tag your CNA friends. They got to stop writing crazy numbers down. Really, that 95.5, that lady's been dead for a while. So so get some realistic numbers. Don't write crazy crap down. Dance like no one's watching. Chart like you're going to court, because you may be going to court. And as always, don't forget your failures, face your fears, and follow your faith. Love you guys.